Hope you can see my screen. Right. Thank you very much for that kind invitation and description. I'm Prabhani Madhubarachi, and today I'll be talking about nutritional challenges in pediatric cancer. So I'll be discussing this presentation with the case scenarios. So hope you can be awake through the presentation. Right. Right. So before going into the case scenarios, a brief introduction, and I know the next couple of lectures will cover these areas in detail. So why nutrition in cancer patients and how is it? Yeah. So how is it different from the other conditions? Right. So causes of malnutrition, it can be cancer related, it can be treatment related, or it can be patient related. And in our setting, it is very dynamic because patients sometimes on chemo versus off chemo, and patients might be at home where they can eat their favorite food, and or they are their intermediate residence or at hospital during episodes of fever versus episodes of no fever, mucositis versus when patient is not having mucositis, when patients are on steroids versus off steroids. One thing we have to keep in our mind is they are always at risk because these patients are immunocompromised throughout their treatment, whether they are running around or whether they are lying on the bed. So they can be neutropenic, they can be not neutropenic, but still they will be immunocompromised throughout their treatment. In fact, even 6 months after the treatment, within those initial 6 months following treatment also, they are still immunocompromised. And the contribution from each of these categories can be vary. Right. So if you are to discuss a little bit more about the treatment-related causes, so chemotherapy gives all sort of, side effects like loss of appetite, early satiety, nausea, vomiting, mucositis, pain, dysphagia, diarrhea, constipation, deterioration in smell and taste, and low albumin. Radiotherapy, in addition to most of the chemotherapeutic side effects, it causes xerostomia, trismus, depending on the region of the radiotherapy, radiation enteritis, and lactose intolerance. Surgery can cause reduced reservoir capacity, causing early satiety, dumping syndrome, vitamin B12 deficiency, short bowel syndrome, malabsorption, and other associated factors. So in our country, so this is still a problem because we ask them to, have a neutropenic diet, and the hospital may not provide the favorite food within that, given guidelines. So the patients always, struggle to find the food that they like when they are in the hospital. Right. Is there an impact? Yes, malnutrition has a significant impact on cancer. So in survival, and it causes malnutrition causes poor tolerance to treatment, and it adds to the financial burden. And there are long-term effects like fatty liver, metabolic syndrome, diabetes mellitus, impaired growth, and metabolic bone disease, food aversion, and impact on other major organs as well, and adding to psychosocial issues as well. And it definitely reduces quality of life and increase the infection risk. So early intervention improves treatment tolerance, possibility to intensify chemotherapy, and survival. So this study was conducted in India, TMH. So they found if you introduce ready-to-use therapeutic food for our patients, they have noticed weight gain and great increase in the fat mass. And fever subjects on this arm had episodes of severe infection, treatment delays, severe mucositis, and treatment-related toxicity. So they have concluded incorporating RTF into a healthy, balanced diet should be considered in undernourished children with cancer. So there's no doubt nutrition plays an important role in cancer management. So I'll moving into my first case. Right. So 10-year-old boy presenting with lymphedema for 8 weeks and diarrhea for 6 weeks. So actually all these cases are from what I have witnessed in Sri Lanka or during my foreign practice. This patient uh, was investigated for a longer period without a diagnosis, because actually the first lymph node biopsy came as non-malignant. However, patient was having diarrhea. So there was a 10 kg weight loss during the last 2 months when patient presented to me, and bone marrow biopsy revealed ETP-ALL with massive parietic node enlargement causing bowel obstruction and bowel compression. So it's very important to identify all causes of loss of weight in these sort of patients. So patient was obviously having uh, lack of food intake, reduced appetite, and there was malabsorption. The bowel was significantly compressed by these huge lymph node masses. So there was obstruction, and ETP-ALL is an extremely aggressive type of leukemia, and it caused cancer cachexia as well. So it's very important to get the baseline evaluation of these nutritional parameters. An urgent nutritional evaluation is extremely important. So I know there are topics, so I will just go through the slide quickly. Cachexia, as you all know, a multifactorial metabolic syndrome characterized by loss of skeletal muscle with or without fat loss, reduced food intake. It's a systemic inflammation, not fully reversible by conventional methods of nutrition management. And it leads to progressive functional impairment. And this is seen in 50 to 80% of patients with advanced cancer. It's not rare. Impact on performance status, infection risk and quality of life, treatment tolerance and delayed treatment cycles, poor wound healing, and it causes 10 to 20% of cancer-related deaths, which is very significant. Right. So the case 2 is a 9-year-old boy with recurrent metastatic osteosarcoma with progressive enlargement of the pelvic mass, and the bilateral lung mets. There's a 5 kg weight loss over the 2 months. So there are so many kids like this. I think you all have encountered, I'm pretty sure. So we have to get the picture. Now the patient is palliative, probably going towards his terminal, stage of the illness. So chemotherapeutic agents will not carry a major benefit in this particular child. So nutritional rehabilitation should be decided on the expected lifespan, performance status, and the activity level, cancer morbidity. So in this patient, actually, the pelvic mass was like extending proximally, compressing the bowel. So whether there's bowel compression and cachexia, and what actually patients wishes from us as well. So severe nausea with functional gut, we can always try enteral nutrition. Bowel obstruction, malabsorption, ideal setting, it should be home parenteral nutrition, which we don't have in Sri Lanka. So risk of dying from malnutrition versus that from cancer progression should be evaluated. Risk of dying from malnutrition, um, uh, if it is more than that from the cancer progression, we always have to manage with regard to the nutritional evaluation and rehabilitation as well. So case 3, it's very common among our patients. 9-year-old boy with newly diagnosed nasopharyngeal tumor, presented with loss of weight following chemotherapy. So chemotherapy causes all these side effects we have mentioned. So loss of appetite, nausea, vomiting, deterioration of smell and taste. So certain chemotherapeutic agents cause significant amount of nausea and vomiting. And depending on the effect, so upper GI causes oral mucositis, ulcers, leading to lack of food intake and fluid intake, and causing pain and dysphagia as well. So lower GI symptoms involves mucositis, diarrhea, paralytic ileus, and constipation. On top of that, depending on the tumor location, mainly in solid tumors, so if it is CNS, they have impaired swallowing. So we need to get involved with the SOUL team, swallowing and speech therapy team to assess their patients' swallowing. And if it is oral or oropharyngeal tumors, a difficult mastication and swallowing. So in this patient, actually the tumor was advancing distally to the oropharynx. So there was a problem. And if it's in esophageal cancers, we have seen this is very common with adults, dysphagia and odynophagia. If it is the stomach involvement, early satiety, gastric outlet obstruction syndrome. If it is bowel, constipation, diarrhea, bowel obstruction, and if there are abdominal masses or lymph nodes, constipation or compression of the bowel. So psychosocial issues, difficult adjustment to the hospital. These are new patients. They're still struggling to um, go home without understanding the severity of the illness. And they are on a neutropenic diet, unavailability of the preferred food choices. So food myths like cold food and like in Sri Lanka, I think our staple food is rice. So parents often think if the patient is not eating rice, so patient is not eating anything. So they don't try to substitute with other carbohydrate sources where patient might willingly eat. And so in adolescence, the other biggest problem is anticipatory vomiting. So the importance of timely NG or PEG feeding, enteral feeding is very important. So for this particular patient, we inserted a PEG tube, and it really worked well throughout the treatment because this treatment carries severe mucositis, and radiotherapy also causes severe oral mucositis grade 3 to 4. But in spite of all this toxicity, patient was able to continue the nutritional requirement, and there were no weight loss after that, and patient completed treatment, and patient is well even now. And so in other countries, like certain countries, we have these portable, very fancy looking NG uh, NG with the pump where they can connect it to the NG tube, and patients, even the children can carry in their as a backpack. So which is very convenient to have NG feeds without any disruption. Right. So this is CCLG, that is Children's Cancer and Leukemia Group in UK. So they have guidelines for the management of chemotherapy-induced nausea, vomiting. So just want to highlight. So there are we categorize our chemotherapeutic agents or the regimes as very high hematogenic, moderate hematogenic, low hematogenic, and minimal hematogenic. So certain chemotherapeutic agents are the chemotherapeutic agent itself can cause severe nausea, vomiting. So if we know that what sort of chemotherapeutic agent patient is receiving, so we have to offer adequate antiemetics, a combination of antiemetics, and make sure the patient is maintaining nutrition, and watch for electrolyte imbalances as well. So for the anticipatory nausea and vomiting, the first line management is lorazepam. There are certain other management medications are available, but I would like to say it's very refractory, and patients, I mean, these adolescent patients, they tend to remember. It's easier to go through the first or the second cycle, but thereafter they tend to vomit throughout the cycle or even before starting the chemotherapeutic cycle as well. So case number 4. Again, this is very common with leukemia patients. 5-year-old girl with BALL causing weight gain during chemotherapy. So why they gain weight? So increased appetite, it can be due to endogenous or exogenous glucocorticoids. So in our practice, leukemia is the commonest malignancy in children. So as the part of their treatment, steroids are given, high doses for 5 weeks. So that's quite a significant period, and they tend to increase appetite, and as well as develop the cushingoid state as well. And on top of that, they get fluid retention due to hyperhydration or low albumin status due to asparaginase. And as I mentioned, the cushingoid state. And then so in palliative patients, especially with the massive like tumor bulk, they can have also increased weight, although the patient is cachectic. So we really have to look into the patient and see whether the patient is gaining weight due to fluid overload, or is this because of the cushingoid features, or whether the patient is purely eating a lot of carbohydrates with the increased appetite, or whether there's a hormonal imbalance, or sometimes if there's significant gaseous distension. So they can still have, a little bit of weight gain in spite of other features of malnutrition. So always, other than that, we always have to, have an accurate scale with a standard calibration, and always we have to measure the weight with the dry diaper or with the similar light clothing. So it's important to measure the weight and the other nutritional parameters at the diagnosis before commencing hyperhydration and steroids. So for instance, patient come throughout the day, even at 12 midnight, and so there's a weight. So usually in the ward, we just measure the weight and the height. But next day onwards, soon after, we start hyperhydration for the suspected leukemia patients in order to prevent hemolysis. So next day, the weight is gone up from 2 kg. But the nutritional doctor comes on, after 2 days, and their baseline weight is recorded as a wrong weight. So make sure you get the correct weight at the very beginning. So that should be the baseline weight for the patient. And getting the weight right is very important, especially when they are overweight. So this is again a true story. A girl was diagnosed to be having primary HLH, that is hemophagocytic lymphohistiocytosis. So they need early transplant when they are during their infancy. So now this child is 3 years old, and she is waiting for her third hematopoietic stem cell transplant. So she was heavily cushingoid due to prolonged steroids due to her previous graft failures. So we considered 3 weights for this child. So the total body weight was 28.6 kg for this 3-year-old girl, right? So it's definitely overweight. But then we calculated other parameters like ideal body weight, clean body mass, adjusted body weight. So depending on these measurements, we have to decide the drug dosing. So there are knowledge on pharmacokinetics and dynamics are very important. So chemotherapy dosing were prescribed as per the adjusted body weight, and then acyclovir, IVIG as per the ideal body weight, paracetamol as per the adjusted body weight, piperacillin, tazobactam, teicoplanin, liposomal amphotericin as per the total body weight. Right. So case number 5, 10-year-old boy with TALL while on induction chemotherapy complains of constipation. So this is again a very common situation in our patients, because our patients are on a lot of drugs that can cause paralytic ileus and constipation. So all cancer patients should be evaluated for constipation assessment, history, examination, and stool gallery. So that is something I really practice in the ward. You all have to know the consistency of the stools rather than saying it's normal. I mean, my normal is different to your normal and the patient's normal. So we all have to stick to one standard measurement. And stool gallery makes it very easy to categorize when parents and the mothers are not having a proper knowledge. And history is very important. So opioids, so like morphine and serotonin, 5-HT3 receptor antagonists like ondansetron, vincristine, vincristine, they are backbone of ALL treatment. So basically, they are on these drugs weekly basis, sometimes opioids for a lengthy period. So make sure patient is not constipated. So electrolytes, corrected calcium, thyroid function, all these have to be measured. And further evaluation is needed if there are severe symptoms, sudden changes in number and consistency of the bowel movements, blood in the stools, brain X-ray shows it is a very good guide to see the extent of the fecal loading like this one. So when I asked this patient, when was the last time patient opened bowel? They could not remember. Patient was with the grandmother. Both could not remember. So you can see the patient had, loaded stools, and it gives, different stages of stool, fecal consistency. Uh, highlighting the patient has not opened bowel for a long period. And constipation during infancy, it's very important. Sometimes they don't have full complete features of Hirschsprung's, but they can have small segments of aganglionic segments, which can be very important and give sinister problems during their chemotherapeutic agents, because the moment they become paralytic ileus, these segments can give rise to even partial obstructions. So bowel movements. So just wanna, this is the normal bowel movement, and so this is the intestine also. This way, the reduced bowel movements, obstruction and reduced bowel movements. So the common thing is, and this is the increased bowel movements. So the reduced bowel movements, constipation or paralytic ileus. So causes like low fiber diet. So this is a bigger problem than cancer, I would say. So a lot of parents these days, they don't give their children vegetables of fiber containing diet. They are very proudly say, my child is, eating pasta and all these, and, getting formula milk, and they are not bothered to give their child a balanced diet with adequate fiber. So because of that, we see constipation very often. And with our drugs that cause paralytic ileus, they can have um, even going to intestinal obstructions, even sometimes partial, because with all these, it's very difficult to have bowel obstructed, even with, functional obstructions are quite, I would say they are not rare. So diarrhea or whatever in lay terms, there's again a range when it comes to increased bowel movements like infections, gastroenteritis, and C. diff. And again, certain chemotherapeutic agents like 5-FU, they cause diarrhea, electrolyte imbalances, radiation enteritis. And as a part of the cancer also can be, diarrhea can be a symptom. And GVHD in allogenic stem cell transplant. And then we'll be discussing the next case. So that is necrotizing enterocolitis, which is carrying they are almost fatal in a neutropenic setting. So 7-year-old boy with AML complaining of diarrhea following chemotherapy. So what is this diarrhea? I mean, it can be, so the common ones are like, gastroenteritis. So we always ask, have you had food from outside? Did you have any unhealthy food? Right? Because it's easier to manage. And it can very well be overflow diarrhea, because these patients are having paralytic ileus, constipated. If you have not managed these patients from the very beginning, it's very common to have overflow diarrhea, because mother will notice only when the patient has, loose stools or like watery stools as the outcome, I mean, as a consequence of stool fecal loading and impaction. So versus necrotizing enterocolitis, that is, we call it NEC. So this carries a high mortality rate. So there's a mucosal damage causing loss of mucosal integrity, and neutropenia is there, and it causes impaired host defense, microbial invasion, translocation of gut flora to the bowel wall, and then bowel wall inflammation is also there, causing necrosis, and all these cause edema, inflammation, bowel wall thickening, and ischemia due to increased intramural pressure, microvascular compromise, progress to transmural necrosis, and possible perforation. So the commonest site is cecum because it has the least blood supply and high bacterial load, and the cecum has a distensible lumen. So clinical features, most of the time they have fever, they have abdominal pain and tenderness most of the time. And so this is a tender abdomen without bowel sounds. So that is how we differentiate it from paretic ileus, because this abdomen is usually tender. And investigations will show neutropenia. CT abdomen is diagnostic where it shows bowel wall thickening and pneumatosis, which is a late sign. And blood cultures will show bacteremia and high lactate and all features of sepsis. Right. So my first question, I mean, this is a question to all the people dealing with nutrition. I think you're going to be a better judge to give this answer. What is the best nutritional parameter to assess nutritional status in patients with cancer? So there are so many parameters, but I would say weight alone is not a good parameter, because as I mentioned, weight gain can be due to so many things, and weight alone is not a proper guidance. So you really have to look into the fat mass and the lean body mass to assess patients' nutritional status. Question number 2, and this is the last, slide. 18-month-old. So this is a relatively new patient, which is very unfortunate. 18-month-old girl brought to the local hospital with abdominal distension. She was followed up at a local nutritional clinic, and this was the 4th child in the family. Birth weight was 2.17, which is low. Weaning started at 4 months due to the poor weight gain, I would say. Patient was on BP 100. And this is the child. Right. I think take a moment and see, I mean, at a glance, what you can identify. So the abdomen is huge. I mean, it's obviously distended. So the situation was actually the parents came from a very poor socioeconomic background. Patient was offered to go to the pediatric clinic as well, but unfortunately they did not have the financial support to travel to the hospital, although the care was free of charge. Sri Lanka, we have free health system, but unfortunately patient was not followed up at a pediatric clinic. And if you see the weight, I mean, this is very obvious. Even though the patient, so the weaning was started here, patient was on BP 100 throughout, but there's no weight gain. There's a bit of weight gain. Probably this is the tumor. Actually, patient came with bilateral veins. So this is where, bit of our theory knowledge is also important. So patient mother says, now this is 18 months. Patient cannot walk. Patient can only stand with support. So there's growth retardation, developmental delay, and very late we diagnosed bilateral Williams tumor. The whole tumor is occupied by this, left side. It's a massive tumor in the left side. Right side also there's a significant palpable tumor. So this is probably a syndromic patient. We are still, we have just done the genetic referral, and we haven't received the reports yet, and all the other referrals are being done right now. So syndrome called Wagner, so which has Wilms tumor and Ridia, genital abnormalities, and growth retardation. So we really have to look into the patient apart from these, parameters as well. Right. Thank you very much. I think I'm happy to take the questions. I think probably at the end of the session. Thank you.
Thank you very much for the kind introduction and for the previous speaker, because for the overall introduction, it makes my task easy. And for the next 20 minutes, we will be discussing about the nutritional approach to radiation enteritis. So, brief introduction about the Sri Lankan setting. So there are oncology centers distributed all over the country, but the side effects of these treatment patients do present to other hospitals as well. So awareness about the side effects are very important in that setup. Oncology treatment nowadays are very effective in reducing the tumor burden and extending the lifespan. And they're also very specific and targeting the needed tissue. But exposure of healthy tissue will definitely give side effects. And these side effects will reduce the treatment efficacy, reduce the food intake and make the patient malnourished, reduce the quality of life, and potentially even lead to treatment failures. So, as an umbrella, all the modalities of cancer treatment do give side effects in all the systems of the body, depending on the target tissues and the treatment qualities and the patient factors. But today we are only going to look at the small intestine and what radiotherapy does to the small intestine. So my objective is to discuss what is radiation enteritis, to understand the pathophysiology, and know how to clinically approach a patient, and how to nutritionally approach a patient, and if time permits, to discuss a case scenario. So the radiotherapy can be given in palliative treatment intent or treatment intent itself. Radiation-induced toxicity will damage the normal tissue in the radiation field as well. It will not look whether this is a tumor or a normal tissue. So because of this, if the GI tract is affected, there will be white cell inflammation in the GI tract, which is called GI mucositis. And the mucositis of the small intestine is what is called enteritis. And involvement of both colon and the small intestine is enterocolitis. So even this radiation delivery is highly precise. If in pelvic irradiation, if there's bowel loops involved, it can give rise to radiation enteritis. So that's what we have to remember. Little bit about the natural history. When there is radiation, there is DNA damage, and there's a lot of inflammation going on. This will lead to infiltration of the cells to the GI tract, mucosa, and all the layers of the GI tract, leading to necrosis of the cells. Epithelial will break down, there will be crypt abscesses and even mucosal ulceration, which gives rise to a leaky gut. So nutrition and fluid losses will be high. On top of that, it increases the permeability of the intestine to the gut pathogens as well, further increasing the mucosal inflammation. In the timeline, this occurs in minutes to weeks' time. But if the inflammatory process goes on top of that, there can be other insults happening to the GI tract, leading to progressive obliteration of the end arteries. and fibrosis. That's the mechanism of chronic inflammation or chronic radiation enteritis that will happen later down the line, even when the radiation was given several years back. This will lead to the complications of radiation enteritis, that is bleeding, strictures, and fistula formation. So if a patient presents late after radiotherapy with the clinical features, we have to remember it can be chronic radiation enteritis. So if you look at the timeline, the acute phase will start within few days, and it will usually settle in 4 to 6 weeks. Patient can present with nausea, vomiting, abdominal cramps, water or blood and blood-stained diarrhea. In the subacute phase, which is within 1 year, may progress to several years, there will be long-term diarrhea, submucosal obstruction, bleeding, abdominal cramps. And the chronic phase, that can be 6 months, years, or even decades, which gives rise to chronic diarrhea, bowel obstruction, pseudo-obstruction, perforation, and even hemorrhage. So, looking at the risk factors for radiation enteritis, the total radiation dose has an effect. The volume of small bowel irradiation does have an effect. Also looking into the history, whether the patient has previous laparotomies or whether there is concurrent chemotherapy going on. The combination modality of treatment will increase the risk. And the common things like diabetes, hypertension, the medical comorbidities, and the GI other diseases will increase the risk. And age is a factor, malnutrition is a factor, smoking, and genetic susceptibility. So, how do we approach a patient? This is bread and butter of all the clinical knowledge and the clinical workup we do, history, examination, investigation. So it is very important to identify radiation enteritis by your history examination and the few investigations that we do have. So symptom analysis and looking for the differential diagnosis of radiation enteritis, like other causes of diarrhea if the patient presents with prolonged diarrhea, is important. And then causes and complications of it, looking into the effect of oral intake, what has happened to it now, whether the patient has symptoms and signs of micronutrient deficiency features, and what is the impact on life and the social history. An examination, you have to look at the hydration state. If they come with nausea, bowel obstruction, or diarrhea, their hydration may be limited. And the anthropometry. Never forget edema-free weight. Previous speaker also emphasized it because we can be misguided. And that can't be the only nutritional parameter that you go by. If you have BIA, body composition analysis, take use of it. Phase angle is a prognostic marker, take use of this. Muscle mass and subcutaneous fat loss has to be assessed, sarcopenia and cachexia, and then micronutrient deficiency features and abdominal examination, and rest of the examination as well. So, looking into the investigations, there will not be a single thing that will tell you this is radiation enteritis. It's the history and examination together. You have to come to the diagnosis, but it's not a diagnosis of exclusion. You have to consider it as a diagnosis, but meantime, we have to look for the other differential diagnosis and exclude them. So looking into the full blood count for infection signs and hemoglobin is important. Electrolyte abnormalities are very common because of the diarrhea and the losses in the vomiting. Acid-base balance, creatinine, liver profile. And if you all have micronutrient profiles, which we do not have, so take use of that. And the first line investigations, plain X-ray, CT, MRI, and contrast studies do help in selected patients. And the second line investigations are capsule endoscopy and enteroscopy that is done in very selective amount of patients. because if there's a stricture due to radiation, these capsules can get entrapped. So only in selective patients that they do. And enteroscopes can't reach the small intestine that well. So only in the distal part, the gastroenterologist will be happy to do, but otherwise it's rarely done. And there are, in literature, there talk about citrulline, which is a biomarker for intestinal failure, and also about fecal calprotectin and lactoferrin. But these will only tell that there is an inflammation in the GI tract. So, coming on to the nutritional approach. Even there are commonly used words, multifaceted and multidisciplinary approach, holistic patient-centered approach. What does it mean? What it means is that we have to get together oncologist, gastroenterologist, nutrition team, radiology team, and nurses, patient, and the caregivers. Then only we can come to a definitive plan. And we have to know what are the objectives of the patient and objectives of the treatment. Is this patient on palliative care? Is this patient a cancer survivor? If a cancer survivor, it is an objective to intervene with the cancer treatment side effects. So looking into these are important, and addressing the barriers to provide nutrition, such as pain management, psychological distress of the cancer survivor and the caregiver, is important. So for these, we need the help of the other team members. The proper plan we have to make by looking into the nutritional requirements. So I can't give a number for you to say this much of energy, this much of protein. So energy and protein depends on the patient requirement. For example, most patients will be malnourished. So for malnourished patients, we can start with a higher energy and higher protein content, but keeping in mind the refeeding syndrome. And also, we have to remember there are a lot of losses. If there's vomiting, if there's diarrhea, these losses has to be considered. Whether the patient is having a stoma has to be considered when you are looking into the nutritional requirement, and that losses has to be calculated. And obviously, if there's a intestinal obstruction, even we calculate the nutrition requirement, we have to look into the modality of giving it. And then addressing the barriers, as I said, for oral feeding, like dysgeusia. But this does not mean we always have to start with oral feeding. If there's an indication, such as in intestinal obstruction, then we have to start with that, what is specific for the patient. So it will be parenteral nutrition. But if we can escalate on the oral feeding, oral nutrition supplements can be given, and maybe if there's a gap, we can supplement with enteral nutrition, especially with nocturnal feeds when the patient is asleep. So her day-to-day activities will not be compromised. And then supplementary PN, we can give in hospital, but home parenteral nutrition is not available in Sri Lanka. This also, we can give full PN, or we can give PN for hydration and electrolytes only. So in UK, there were some patients who were on hydration and electrolyte only regimes for radiation enteritis. It can be daily, or it can be 3 times a week, where they come to the hospital and get it, or home-based hydration and electrolytes. So depending on the patient, we have to modify. So this picture was directly taken from the ESPEN. Even it says chronic intestinal failure. We have to remember radiation enteritis do fall to all categories. It's a matter of acute intestinal failure as well, but type 2, type 3 intestinal failure also can be caused by radiation enteritis. I will give just the principles of management. So acute and subacute radiation enteritis depends on the symptoms and the symptom severity. We have to address symptoms with medications and other modalities. So antidiarrheals, loperamide can be prescribed, and also fluoroquinolones are mentioned, but the resistance to antibiotics is an issue. And if there's long-term non-responders to loperamide, octreotide can be used as an anti-secretory medication. Antiemetics can be used in patients with vomiting. And there's a new drug, imifostine. Even it's new to me, I'm not sure because this I have not used. So I'm not very much aware of this medication, but it is documented in the literature. Dietary modification, short-term low-fiber diets are recommended. So this is the only diet type that was mentioned because of the stricture formation and the inflammation. So lot of fiber, it can reduce the energy density of the feed. It can act as an osmotically active particle. It also can take up space and cause increase in the inflammatory process. So because of these effects, it is recommended short term. And if the oral intake is not sufficient, likewise, enteral nutrition can be given. In the new guidelines, they do talk about complete bowel rest for acute symptom reduction and going for short-term parenteral nutrition. So if there is a patient with severe symptoms, short-term parenteral nutrition can be tried as the first modality. Surgery, usually acute radiation enteritis, they do not subject to surgery. They usually take a conservative approach till the inflammation subsides. As opposed to that, chronic radiation enteritis, again we have to look for the symptom control and other possible causes to address, like small bowel bacterial overgrowth. If so, treat with antibiotics. Pancreatic insufficiency, we can treat with PERT. So these causes that can be addressed should be addressed. And then provision of nutrition. We can alter the diet and see if there's lactase deficiency. If you're suspecting, we can take the approach of the elimination diets, but otherwise we can't. And food fortification can be taken into consideration, oral nutrition supplements and enteral nutrition. The long-term parenteral nutrition, especially if the damage of the gut is widespread. Surgery do have a place in strictures, obstructions, where they go for surgeries because this can be irreversible. And in localized disease, it is said that surgery can be tried, but not in widespread diseases because the patients will end up with a short, small bowel. A word about parenteral nutrition. So there are specific indications where you can go for parenteral nutrition when there's electrolyte imbalances, which cannot be mitigated with oral and enteral route, severe malnutrition, and pain elicited by oral and enteral feeding, where there's intestinal failure. So in type 2 and 3 intestinal failure, like I said before, we can use it. And to restore nutrition, radiological and clinical parameters, it is said parenteral nutrition for several months is better than elemental diet alone. Looking into the outcomes of home parenteral nutrition patients, they talk about survival, intestinal rehabilitation, and oral nutrition autonomy. So even the patient has been on home parenteral nutrition, there were patients who were nicely weaned off from PN and has started on oral nutrition. But in our setting, since we do not have HPN, we go by nutrition rehabilitation, change back to the usual diet, and addressing the sarcopenia as our outcomes. To answer specific questions, is there a specific nutrition regimes or diets? No specific diet to control symptoms, but case by case we can evaluate and do. For example, lactose intolerance, lactose-free diet. Is there a place for immunonutrients? It's debatable because glutamine is discussed widely because it gives a shield to the intestinal ulceration, but I couldn't find a place to say this has to be given and this is the best result. Is there a place for gut microbial modulation? It is said that probiotics have a better effect on diarrhea as opposed to mucositis itself because there is gut dysbiosis with radiation. So it's not for mucositis, But for symptoms, sometimes it might have a place, but these are non-conclusive. Also, there are a lot of food and nutrition supplements, micronutrients that are widely discussed, even medications in literature for radiation enteritis. I'll quickly go through this case scenario. This is a patient who we recently managed, 67-year-old cancer survivor. Cervical cancer radiotherapy was given 4 years back, presenting with diarrhea for 7 months. She had a BMI of 20 with the edema-free weight, and GLIM was acute malnutrition criteria was fulfilled. But this is a chronic malnutrition on top there is acute deterioration. She was dehydrated, edematous, micronutrient deficiencies was there, sore bottom was there. No features of intestinal obstruction. It was diarrhea. And that's why patient has not come to the hospital, because it was diarrhea and she was not willing to come to the hospital. Investigations showed electrolyte imbalances, low potassium, low magnesium, low phosphate, and low sodium. Acid-base imbalance was there. There was acidosis, acute kidney injury, and anemia. We were invited as a part of the MDT to manage the patient. After a lot of discussions, because to identify what the patient wanted was very difficult. But we had to stabilize the patient, so IV replacement of electrolytes was done. Ongoing losses were given with IV initially, then we changed to oral maintenance. Hydration and hypoglycemia was corrected initially with IV fluids and gradual increase of oral feeds. Oral nutrition supplements was used and they were divided throughout the day to get the consistent calorie and protein and the glucose requirements to avoid hypoglycemia. And we were thinking of refeeding syndrome, so thiamine replacement, electrolyte replacement was given. And I started with 25 kilogram per kg and increased to 40 energy requirement, and protein started with 1.2 and increased to 1.3 grams per kg per day. And we managed the diarrhea symptomatically, and loperamide in escalation doses were started. And addressing the barriers for oral intake, especially pain management, antispasmodics, and psychology referral, oral hygiene, because even having a poor oral hygiene will limit the oral intake. This has to be addressed. And the psychology support for primary caregiver and counseling became very effective because they didn't know, they didn't understand the importance of giving nutrition and addressing the diarrhea quickly and why we should do it. And then because the patient was too shy or was in a low mood to come to the hospital, this was addressed. And after stabilization, we changed to food-based nutrition therapy, and micronutrients were given in the doses, but oral electrolyte replacement, still the patient is ongoing, oral electrolyte replacement is going on. And appetite improvement was another aspect we looked into. And then monitoring. Monitoring is very important. They can relapse. They can go into mood shifts. So we have to monitor these patients and we have to be always supportive. Thank you.
I hope you all audible me.
Yes.
Okay. Today I'll be discussing nutritional support in obstructive GI malignancies, specifically the role of enteral nutrition versus parenteral nutrition. So I must say these decisions are really straightforward, requiring us to balance physiology, disease stage, patient comfort, and resource limitations, particularly in clinical settings. So in the next 20 minutes, I will focus on how to translate guidelines into effective bedside decision making. So I will discuss the clinical problem, pathophysiology of malnutrition, overview of nutrition modalities with the explanation of enteral and parenteral nutrition with risks and advantages, evidence comparison, clinical decision framework, and finally the regional consideration relevant to our setting. As we all know, malnutrition is extremely common in gastrointestinal cancers, affecting approximately 40 to 80% of patients at the time of diagnosis. So this wide range reflects differences in tumor type, stage, and patient population. But the key message here is that malnutrition is the rule rather than the exception. The problem becomes even more severe in obstructive tumors, where a mechanical blockage prevents adequate oral intake. Patients frequently experience early satiety, persistent nausea, vomiting, which all significantly reduce their ability to maintain adequate nutrition. Over time, this can lead to progressive decline in nutritional status. Clinically, this translates into increased infection rates, increased mortality with poor treatment tolerance, and increased complications, including delayed wound healing and delayed recovery. So, it is important to emphasize that malnutrition is not merely a consequence of cancer, but an independent predictor of poor clinical outcome. So when we come to the pathophysiology of malnutrition, as the previous lecturer discussed, the mechanical obstruction leads to reduced intake because patients are physically unable to consume enough food, even if they have desire to eat. Then the cancer cachexia plays a major role. This is driven by systemic inflammation, where cytokines such as TNF-alpha increase metabolic demand while simultaneously accelerating the muscle protein breakdown. So even when intake is partially maintained, the body is in a catabolic state. Treatment-related factors further worsen nutritional status. Surgery, chemotherapy, and radiotherapy can all contribute through complications such as ileus, mucositis, and anorexia. An important point to highlight is that malnutrition often begins even before the cancer is diagnosed. This reinforces the need for early and proactive nutritional assessment rather than waiting for visible weight loss. So in this clinical context, there are two primary nutritional support modalities, which I am going to discuss today, is enteral nutrition and parenteral nutrition. Enteral nutrition involves delivering nutrients through the gastrointestinal tract, thereby maintaining normal digestive and absorptive functions and preserving the gut integrity and immune function. In contrast, parenteral nutrition bypasses the gastrointestinal tract entirely and delivers the nutrients intravenously, making it suitable when the gut is not functional. The key differences is that enteral nutrition works with physiology, while the parenteral nutrition bypasses the gut. So, enteral nutrition has several advantages. As I mentioned earlier, it helps maintain gut mucosal integrity, which plays a critical role in preventing bacterial translocation and infections. It also supports immune function and is associated with low rates of septic complications compared to parenteral nutrition. From a practical perspective, it is more cost-effective as well. However, it is not without limitations. What are the limitations? It cannot be used in cases of complete obstructions, which may require invasive procedures such as PEG or jejunostomy for access, and can sometimes be associated with aspiration risk, intolerance, including nausea and diarrhea. So while it is preferred, it is not always feasible. Then parenteral nutrition, on the other hand, is life-saving when enteral feeding is not possible. It allows us to deliver precise amounts of nutrients tailored to the patient's metabolic needs, independent of gastrointestinal function. This makes it invaluable in patients with complete obstruction or severe gastrointestinal dysfunctions, such as bowel ischemia or IBS. But it is associated with significant risks, including catheter-related bloodstream infections, metabolic complications such as hyperglycemia, electrolyte imbalances, liver dysfunctions, and higher healthcare cost. Therefore, while it is an essential modality, it must be used and monitored carefully while patient is on parenteral nutrition support. So when we look at the available evidence, a consistent pattern emerges. Studies report enteral nutrition is associated with reduced infection rates, shorter hospital stays, and lower healthcare cost. Parenteral nutrition remains crucial for patients in whom enteral feeding is not feasible, but it carries higher risks. However, when it comes to mortality outcomes, evidences show no significant difference in mortality between enteral nutrition or parenteral nutrition, which indicates that survival is nutritionally supported but not nutrition route dependent. This brings us the fundamental guiding principle in clinical nutrition, that is, if the gut works, use it. Even partial gastrointestinal function is often sufficient to justify enteral feeding. This principle reflects both physiological reasoning and strong clinical evidence. American and European societies for parenteral and enteral nutrition all consistently recommend that in obstructive GI cancers, enteral nutrition should be used wherever the gut is functional, while preserving parenteral nutrition only for cases where enteral nutrition is impossible or inadequate. So, in practice, decision-making can be simplified using a structured approach. First, we have to assess the severity and location of the obstruction and functionality of the remaining gut. Then determine whether the obstruction can be bypassed, either surgically or endoscopically. If enteral feeding distal to the obstruction is possible, then enteral nutrition should be always considered. If not, parenteral nutrition becomes necessary. It is also important to reassess patient regularly as clinical condition can change, allowing transition from parenteral nutrition to enteral feeding. Ultimately, enteral nutrition is preferred in partial obstruction or when bypass is feasible, while parenteral nutrition is reserved for complete obstruction or non-functional gut status. But remember, these decisions are dynamic and must always be individualized. In specific clinical scenarios, such as esophageal and gastric cancers, enteral feeding can be achieved through nasogastric or nasojejunal tubes, PEG placements or jejunostomy, which provides feeding access distal to the obstruction. In advanced obstruction, where multiple levels are involved or bypass is not possible, parenteral nutrition may be required. Alternative approaches such as endoscopic stenting or combination therapy using both enteral and parenteral nutrition can also be considered in certain patients. An important point here is that preoperative nutritional optimization is specifically important as it improves surgical outcome. So a little bit about the palliative care context. Palliative care present unique challenges when it comes to nutritional support. Clinicians must carefully evaluate whether the nutrition will truly improve the quality of life, consider the patient's prognosis, and respect the patient's preferences. While nutrition support may reduce hunger and improve comfort, it can also introduce burdens such as invasive procedures, complications, and hospitalizations. Therefore, these decisions again must be individualized and aligned with the patient's goals of care. Then coming to our regional local context, in South Asian context, several additional factors come into play. So, patients often present late with advanced disease and pre-existing malnutrition. And also resource limitations make cost effectiveness a key consideration in decision making. As a result, enteral nutrition is generally preferred because it is less expensive, associated with fewer complications, and can often be managed in outpatient settings. However, we must also recognize the challenges, including limited access to specialized nutrition teams and the need for better patient education. So, in summary, enteral nutrition should be used whenever feasible, as it is more physiological, safer, and cost effective. Parenteral nutrition remains essential when enteral feeding is not feasible despite its risk. Most importantly, nutritional care must be individualized based on patient's clinical condition, prognosis, and goals of care. Finally, I would say that the key to good clinical practice lies not in choosing one modality over the other, but in knowing when to use each and when to transition between them. So these are my references, and thank you for your attention.
Discussing the nutritional support in palliative care and hospice care, and we will be discussing with the evidence-based practice and also related to some ethical decision making. First of all, I would like to disclose my statement, as I don't have any commercial or financial interest related to the content or delivery of this session. And for the next few minutes, we will be discussing around these lines. This will be the roadmap. First, we will explain the palliative care. What are the stages of palliative care, the nutritional needs in palliative care, what is artificial hydration, nutrition and hydration, and at the end, a life case study. So, what actually the nutrition in palliative care is? We often confuse palliative care with the hospice care or the comfort care, or we think that palliative care is like something end of the life, or related to the terminal illness. But actually, what is the concept behind it? So basically, first we need to understand the palliative care. It is something specialized medical approach with the focus on relatively improving quality of life, priorly improving quality of life for those individuals living with a serious or life-threatening illness. We often limit it to the oncology care. Of course, it is widely used in the oncology care, but it's not limited to it. And in this palliative care, we manage the symptoms, provide the psychosocial support, the appropriate nutritional support, and the alignment of this care with the patient's goal, and regardless of the prognosis or the treatment stage. So basically, palliative care is a much bigger umbrella. The end of life care, or the terminal care, or the hospice care are the sub part of it. In this slide, you can see the continuum of care. It is not just end of the life care. It can begin early, and it is very good to initiate palliative care early in such situations where the cure is not possible, but the treatment is possible, or but the management of symptoms is possible. The outer layer of this figure explains that overall palliative care, which is mainly focused on symptom control, quality of life, and support for both patients and families, and also included the palliative surgery. And as we move down the inwards towards the end of life care, the condition is no longer when that condition is no longer creative, the focus shifts towards the comfort, supportive care, psychosocial support, and typically in the last maybe in the last few years, or in the last few months or days of the life. And then last, the terminal illness is days to hours of life. We must be focused on the spiritual care, mainly the symptoms management, and of course this not only the psychosocial support to the patient, but with the family as well. So these are the 5 stages of palliative care. The first one is the stable stage, when the patient is stable, the patient is not having any kind of serious side effects or the serious illnesses. This is the stable stage. This is the stage when the patient know that their diagnosis is is not treatable completely. So this is the ideal time to introduce the palliative care. Then the second stage is the developing stage, when there are sudden changes, medical interventions required, there are, or maybe there are some treatment related challenges. And then the third stage is deteriorating stage, when the condition is worsening and the increased support is required. Increased and not only increased support, but very careful support. Then the second last stage is the terminal stage, at the end of life care. And the last and most important stage, which is often neglected, the bereavement stage, after the termination of the patient. This stage, I must say, we often neglect, or even we don't bother about it. But it is very, very important stage in palliative care, which is not only related to the patient, but family also require the support. So palliative care is not only limited to the hospital setting or towards any nursing setting, but it is also provided at the home or the nursing care facility or the nursing home. And anywhere, any healthcare facility must be designed to provide the palliative care. um, a few minutes related to the difference between the palliative care and the hospice care. Basically, the palliative care is more focused with the support function to reduce the symptom, to manage the symptom, to maintain the quality of life when the patient is still in treatment or has a longer prognosis. And it includes oral intake optimization, texture modification to improve the targeted supplements if it is beneficial for the patient, and to manage the symptoms affecting the intake. Enteral nutrition is selected in some cases, and even parental nutrition is also in selected when the clear benefits are shown. Whereas in the hospice care, the focus is much related to the comfort, pleasure, the relaxation of the patient, to have a minimal nutrition burden on the patient. And it includes comfort feeding only. Remember, this is an inverted commas, the comfort feeding only, because the patient who is in the hospice care is, of course, suffering from the terminal illness. So the force feeding or heavy feeding will not provide the patient any ease or any support. In reverse, it will even worsen the condition, or it will even worsen the GI condition. There is no calorie or protein targets in hospice care. It is only related to the patient's the patient's acceptability, the patient's tolerance, and even the comfort related to the patient. There must be not aggressive feeding. We should not be very much aggressive in intervention of nutrition in the hospice care. And the minimal medicalization of meals, the ENPN is rarely indicated in such situations when the patient is having the terminal illness, or if we are using in any situation, if the EN or PN is mandatory or it is required, there is no way of having oral nutrition. So we must be cautious about it. And stop nutrition support if it is causing discomfort. If the NG feeding or if any other type of feeding causing any discomfort, we should be reconsider it. Now here comes the which type of nutrition support should be implemented in palliative care. There must be four pillars around which the nutrition support is revolving around. The first one is the symptom management. The second one, we must have a clear goals in our mind, what we are going to achieve. The third one is meal modification, and last, but we should not forget about it, the ethical considerations. The four ethical principles: beneficence, non-maleficence, autonomy, and justice. These all should be kept in mind while planning the palliative care nutrition support. For the symptoms management, most of the patients who are going through with the disease-based symptoms, the disease-based side effects, considering these in all in the nutritional management of it. The meal modification, adjust the meal accordingly, the clarified goals, the ethical considerations. For the symptom management, being a nutritional professionals, it's not that difficult for us to provide a nutrition support, but the difficult thing is to decide to which extent should we go. The loss of appetite, energy dense food, appetite stimulants. We always talk about small meals for nausea, vomiting, soft foods for mucositis, fiber rich foods for constipation. So these are the things which are on our tips. But the challenge is on the ground reality. When we are talking about these things, these are easy, but on the practical application for the patient who is suffering from these conditions or from these issues, it is challenging for them to incorporate in their diet. For meal modification, of course, the texture modification is required to avoid strong odors. There must be cultural and emotional significance of food as well, so we should respect it. The simple foods that give joy and comfort to the patient. We should not be very much restrictive. No, this will aggravate you further. This is not for you. We should be humble related to the choice of food for the patient who is suffering through the terminal illness. And we have to be very clear on the goals of our feeding. The feeding is not only for the sake of feeding, for the sake of completion of calories or the protein or the target achievement. No, we need to ask three questions from ourselves first. The first one is the purpose of nutrition is to prolong the life? Is the goal comfort only? Or is artificial feeding acceptable to the family? If the answer is yes, then we should go with the management accordingly. And then the ethical consideration, when to stop or not initiate the tube feedings. It is not always possible. Of course, as a dietitian, we know that tube feeding is sometimes serve as a life saving or the condition saving. But if the patient is not agree, if it is causing discomfort to the patient, if the family is not agree after so much counseling, explaining pros and cons, so we should respect them. We should respect the patient autonomy. And unnecessary suffering, not only the physical suffering, but the social suffering, the physical suffering, and the emotional suffering as well. And do not forget about the financial sufferings as well. This is also under the domain or under the ethical domain of a dietitian to consider all these things. These are the challenges in palliative care nutrition we always face: the disease progression, the decreased appetite, the metabolic responses, the pain, nausea, treatment side effects, aggressive feeding, prolonged suffering, prolonging life, ethical questions. These all small things made up and ended up to the huge nutritional challenges in the palliative care. So to avoid these things, mostly people who are suffering from anorexia, poor appetite, or early satiety, these are the few things, these are the few points that should be considered. The first one is oral nutrition support. How much, how maximum the patient can be taken orally, we should go for it. We should offer the liquid between meal rather than with meals. Physical activity to stimulate appetite, whatever is tolerable to the patient. Fortified foods, caloric dense food, small frequent meals. It is easy to say it's a fancy statement by providing small and frequent energy dense meals. But frankly speaking, when we are planning these meals, this is easy. But when the patient when we expect from the patient to do it like this, it is difficult at their end. Because most of the time patient is suffering from the nausea, patient is suffering from heavy medications, patient is suffering from some other treatments. So this is a little difficult to incorporate, but we must be supportive in these terms. The second one, which I must say is a golden substance for these patients, is the eicosapentaenoic acid, EPA. And it often reduces the systemic inflammation. It is usually available in the omega-3 fatty acids, which is found in fish oils. And it is shown down the loss of muscle tissue and the tiredness that goes with it. And it decreases the muscle breakdown, and it improves the body weight and lean body mass. There are some practical nutrition tips. The first one, we must say, to boost the meal with the milk powder, we can add the say powder, like soya powder, like protein, add on the protein. The nut powder can also be added. Protein powder can also be added up to the tolerance. Healthy oils can be drizzled over the food, and less meat, and mix the lentils and beans as per the tolerance of the patients. Patient often go through with the diarrhea, so all the conditions related to the diarrhea or the dietary management related to the diarrhea should be incorporated. As I said earlier, palliative care is basically the symptoms management and the improvement of quality of life, and to provide the patient with the ease and comfort. For the constipation, these are all basic guidelines. We have to offer the high fiber foods, we have to maintain the hydration. Lukewarm milk with oil can also be beneficial for it, and high fiber fruits in the limitation of the treatment. Nausea vomitings, the few points related to nausea vomiting, again, small frequent meals. Every time we talk about anything, small frequent meals is top of the list, because this is the savvy. We need to choose the cold or room temperature foods. Lying down post meal, of course, positioning is also important, and this is also the responsibility of a dietitian to explain all these things. And related to the liquids, clear fluids, water, lemon water, ginger tea between meals, whichever is suitable for the patient or for whichever the patient is feeling comfortable with. And avoidance of a strong smell, soaps, perfumes also aggravate the nausea and vomiting. So all these things should also be avoided. Last but not the least, the psychological support or the psychosocial support. The patient is already vulnerable, already physically vulnerable, emotionally, socially vulnerable. So in these situations, palliative care also provide the psychosocial support. A social expert should also be in the palliative care team, not only to counsel patient, provide therapy to the patient, but also to the family. Remember, do not forget about the family in this specific stage of the treatment. Then what could be the nutritional goals in palliative care? What should be our nutritional goals in palliative care? There must be early integration or maybe the late integration. We always in the support of early integration of palliative care. The earlier the integration of palliative care, the much more improved, or I must say, the best outcome we can achieve through this process. Earlier palliative care prevent or reverse nutrient deficiencies. Of course, this is the early palliative care not only prevent, but it will provide because at that time the patient is at a good nutritional status, so we can provide the maximum nutrition, and we are on our open hands to develop the plan. The restrictions are minimal at that stage, and minimum treatment related side effects present. Strength and energy can be improved, quality of life can be improved. But if the palliative care initiated at the later stage, so the focus will be more on the symptom control, the physical care, the psychological support, because already the treatment related side effects are there, the disease related effects are there, and in the late palliative care we should consider the quality of life rather than quantity of life. Frequent sips, these are all the tips we have already discussed. And depending on the physical consequences, previous dietary restrictions should be minimized or stopped. We will discuss in the case study. Most of the time the patient is not only suffering from the cancer but having other comorbidities as well. So we should not be much restricted with these things. Of course, already patient is suffering through a lot, so we have to be modest. And in the late palliative care, to discuss the ongoing benefits of inclusion of nutritional supplements. Then there must be a little discussion about nutritional needs in palliative care. What are the actual nutritional needs in palliative care? The early palliative care typically require 25 to 30 calorie per kg. There is not much difference in the early stage of requirement, not much difference in the requirements or in the nutrition prescription in the early stages. Basically, it is adjusted towards according to the fatigue, the anorexia, the inflammatory burden, the weight trends, and according to the patient's current status. But if the disease progresses and we move towards the end stage phase or the end stage palliative care, there is a natural decline in the metabolic demand, so we have to adjust the calories accordingly. The transitioning patient or the dying patient do not require much energy or much protein or much calories. He or she only requires the supportive energy. The appetite suppression, of course, it is physiological, and we should not force feed in this stage. It will increase the discomfort, and calorie is not a target. The comfort is the target, actually. The comfort food is the target. Protein requirements are 1 to 1.5 gram per kg per day. At the higher end, cancer, cachexia, pressure injuries, chronic infections are there. At the lower end, poor appetite, end of life comfort care is there. And these are related to the Aspen Care Guidelines 2021. Then comes the artificial nutrition and hydration. The artificial nutrition and hydration includes the oral nutrition supplements, enteral nutrition, parental nutrition. Remember, with the caution and with the requirement. Then the artificial hydration. But the key prerequisites are, if it is medically indicated as the justified treatment, there is a clear objective for the intervention. We must be very clear if we are intervening such things. We should have that particular outcome and with the patient consent, and final decision and responsibility lie with the treating physician. So as you see, okay, enteral nutrition consider prognosis and patient desires. First, we must be focused on the oral feeding and encourage social eating and symptom adjustment. If it is not possible at all, then enteral nutrition is the option and parental nutrition is the option as per the patient's condition. So we have to ask ourselves some questions. Patient is in advanced stage disease. So there is a question, is the quality of life improvable? If the answer is yes, then we need to consider the nutritional support. And if the answer is no, the patient's quality of life is not much improvable. So our focus must be on comfort measures, which include oral care, small sips of fluids, and symptom relief. And remember, ethical approach should not be minus from it. This must be the individualized decision making support, and we need to assess the benefit versus the burden assessment, uh, to assess the intervention, if the intervention is benefiting the patient or if it is imposing more burden to the patient and also the family. And for the clinical practice, the focus is on the comfort again and again. Mouth care is an IV fluids and dignity in the end of life care. So every patient require a dignified, comfortable, relaxing transition or the end of life. It is the ethical right of every patient. We should not be much focused. The focus should not be on the patients, that should be like to keep the patient alive. The focus is not like this. The focus is on to make the patient's suffering easy, to make the patient transition easy and relaxing. Because death is something which is inevident, and we should be talking about it more. Here is the life case study. I'm going through it quickly. There was a female who is 65-year-old. She was housewife and she was diagnosed with metastatic ovarian CA, already having a comorbidities of diabetes and hypertension. She underwent procedure of exploratory laparotomy. Ileostomy was made 1.5 months back, and her current complaint was having a high ileostomy output of 1400 to 1600 ml. Bowel movements were of watery diarrhea, increased ileostomy output, disturbed sleep pattern. She don't have any kind of food allergies. These were the anthropometrics of her. She's having a good body mass index now because she recently underwent to the surgery and everything, but it is progressively deteriorating. And she's on insulin and ALT 0.5 milligram. The nutritional supplement, previously she was taking the nutritional supplement, which is disease specific formula, the diabetic formula, and we should have to change it on the semi-elemental formula. And the further plan is to include the protein powder as per the requirement and tolerance of the patient. And the addition of dietary supplements, multivitamin with zinc, remember, and folic acid as well. These are the laboratory parameters of her. You can see the inappropriate, the disturbed pattern of glucose, random glucose, a lower side HB, and lower side of serum creatinine. Her dietary recall intake was including one medium egg with one medium whole wheat homemade chapati or one bread slice with tea. And mid morning, she was taking 2 to 3 dates or 15 to 20 pieces of grapes or one medium banana. Her lunch included some vegetables with curry or curry item, only one piece of chicken, and dinner was same as lunch. She was approximately consuming 1200 to 1400 calories, and her fluid intake in 24 hours was 1 liter. So basically, according to her dietary recall, what was our nutrition prescription was, first we will offer her regular low fiber cooked high protein diet. Here comes the neutropenic diet, not exactly the neutropenic diet, but cooked diet. Semi-elemental formula introduced with 200 ml BID with the standard formulation, and further plan to start protein once the ileostomy output range between 1000 to 1200, means in the appropriate range. This is the chart we have followed related to the ostomy output. the gas forming foods to be avoided, foods that may thicken a stool, the odor producing food should be avoided, foods that may control odor should included, foods that may cause obstruction should be avoided, and foods that may cause diarrhea should be avoided. So a dietary plan was made along these lines. And this is our problem etiology sign and symptom statement. She was having inadequate energy and fluid intake related to the lack of dietary knowledge and increased GI losses and malabsorption, secondary to high ileostomy output. And it is evident by the low oral intake, 1200 to 1400 calories, watery diarrhea, and ileostomy output of 1400 to 1600 ml per day. So on the follow-up, she was admitted due to severe dehydration and electrolyte imbalance, and she was having again the higher ileostomy output. Water intake is reduced in 24 hours because she was considering, and she was concerned that increasing her water intake will increase the ileostomy output, and she restricts her fluid intake and get dehydrated. As per the prescription, she wasn't able to add 7 scoops of semi-elemental powder to 210, which is a standard dilution. She added 7 scoops to only 100 ml. So there was an inappropriate composition of formula. So these are the targets we made the prescription around, and we made some smart goals related to the small steps. The first related to the hydration, the water intake, and the correction of the formula. This was her open wound. On the initial visits, the wound is like this, and on the follow-up visit after 15 to 20 days, the wound is slowly and gradually healing, and it becomes like this. And the patients controlled her ostomy output. She increased her hydration and maintained her electrolytes as well, and her sugar ranges were also maintained. These were the key takeaways from this session, because nutrition and palliative care focus on quality of life rather than aggressive feeding. It must be remembered. And individualized care and patient preferences are essential. Symptom management plays a central role in the nutritional support. As early as we start the palliative care or we put the patient on the palliative care, the options are more visible to us, or the picture is more clear related to the patient. Because most of the time we think, if we think patient is on palliative care, oh, it's a terminal illness, we should not be doing this. It's not like this. We have stages of palliative care, and as per the specific stage, there are specific prescriptions or specific treatments, nutritional treatments we should be focused on. And artificial nutrition should be considered carefully based on the goal of care, and multidisciplinary collaboration always improves the patient outcomes. For the palliative care team, a physician, of course, it's a must, a palliative care dietitian, psychologist, physiotherapist, a social expert. These are the few person, and spiritual expert as well. So these are the few person who made up the team and makes the outcome for the patient improved. These are my references for this presentation. And I must end my presentation with the note that palliative care nutrition is not about adding days to the life, but adding life to the days. Thank you. Any questions?